Okay, so let's do a case in Radiopedia. I don't know what the case will be of, but let's look what we are going to get. So let's start a quiz and let's get something. So we have a coronal T1 weighted imaging of the brain. I still don't show what are the clinical presentation. Let's go throughout the images. So let's try to find something that looks quite abnormal. Okay, here nothing bad. You can see the hippocampus right over here. I don't think it's too much trophy. Maybe there is a little bit of atrophy of the brain, maybe. Not too much. Let's see if there is something enhancing. Nothing really enhancing or something. We see the basal ganglia right over here. The ventricles look fine. Choroid plexus look fine. The hippocampi looks fine. The meninges looks fine. Temporalis muscle. Okay, so let's look at the. Okay, there is something. Wait. Okay, so I think the idea is that we have something in the sella turcica. Maybe this is what we've got. This is maybe a microadenoma. Micro or macroadenoma, I think this is the idea. About the optic nerve, I don't think it causes any compression of the optic nerve, so no visual field effects probably. So this is probably a micro or macroadenoma. I don't see that posterior part of the pituitary, which should be hyperintense. I don't see it. Or maybe I do see it right over here. So let's see the diagnosis. Rathke cleft cyst. Here is a case of Rathke cleft cyst with an intracystic nodule of low signal in T2 weighted image that is visually pathognomonic. So low T2, this is probably this one. Let's look right over here. No, it's not this one. Wait a second, this is not this. This is just the clivus. Let's see corona hypophysis. So the sinuses are near them. Okay, so maybe this is right over here. It's above the sphenoid sinus. Here is the probably the sphenoid sinus. So it should be right over here. Should be right over here. This is probably the cyst. This patient has been under MRI follow-up for 5 years with no detectable changes of the lesion, and frontal headache and blurring of vision. So there is maybe compression of the visual nerve somehow that I really don't see. Okay, see, this was a case of a right cleft cyst. When we are reading a little bit about it, looking at the pituitary gland and biological, pars tuberculis, pars intermedia, pars distalis, we see the pars nervosa and Rathke cleft cyst between them, metamenes in fibular stem. Okay. If large, may cause visual dispersion to correction of the optic nerve, optic chiasm, majority symptomatic, incidental find, especially when under 3 millimeters. Development of rostal rupture from the fourth to the anterior wall of the pouch rising the wall of the cyst typically lined by thin columnar cell epithelium. On imaging, grafted cleft cyst is seen as a well-defined, non-enhancing midline cyst within the cell arising between the anterior and intermediate lobes of the pituitary. 40% are purely intracellular and 60% are supracellular extension. Purely supracellular location, although reported, is rare. An intracystic nodule, sometimes referred to as cyst with dot sign, is represented in 70%. When presented, usually hyperintense on T1 and hypointense on T2 compared to surrounding fluid. And differential treatment, surgical treatment is indicated for cases with symptomatic mass effect. The recurrence of the surgery is 17.5. Symptomatic grafted cyst and craniopharyngioma. Endocrinopathy, growth impairment, and pernicious puberty, hormone replacement, and gonadotropin suppression may be effective. You can see the differential teratoma, epidermoid cyst, arachnoid cyst, craniopharyngioma, cyst pituitary adenoma, hypointense on T2, hyperintense on T2, hypointense, and hyper on T1. Probably this one. So T1, so it's quite hypointense. Okay, nice case. This one about Rathke cleft cyst. We saw how we diagnose it, what is its origin, and what is its presentation, if it has presentation, and then it needs to be treated. What is the treatment? Surgical treatment for symptomatic patients may recur, may be related to craniopharyngioma, and this is it. May cause pituitary dysfunction, headache, and visual disturbance because compression of optic nerve. Pituitary dysfunction, not necessarily clinically evident, but common. Compression of adjacent pituitary, a distortion of pituitary stalk, 70% of symptomatic cases. Increase in prolactin, most common due to stalk effect. What is the stalk effect? Prolactin. Stalk effect, mechanical integration of the porta, transport of dopamine from the hypothalamus to the anterior pituitary gland will reduce inhibition and thus result in malelevation of prolactin. Because probably dopamine inhibits prolactin. Dopamine goes throughout the stalk. If there is stalk compression, dopamine can't come. Dopamine can't reduce the levels of prolactin because dopamine inhibits it. And if there is no dopamine, there is reduction in inhibition of prolactin. Therefore, when there is compression of the stalk of the pituitary to the hypothalamus, there may be what is called stalk effect with elevated prolactin level because of this reason. So this is what I wanted to say about a Rathke cleft cyst. In this case, I didn't know that we will get to Rathke cleft cyst. Probably this thing right over here. No, this thing right over here, because Rathke cleft cyst, Rathke cleft cyst, MRI T2. Okay, let's see if there's, see the Rathke cleft cyst right over here. Okay, this T2, you can see it right over here. On T1, you don't see too much, so it's quite hard on T1. You can see right over here with gadolinium that the Rathke cleft cyst itself maybe didn't enhance, but the other parts did enhance, or especially. I think in T2, the most obvious one. In T1, 50% on hyperintense, 50% on hypointense, usually hyperintense on T2. No contrast enhancement to CCCs, however, a thin enhancement region of surrounding compressed pituitary tissue may be apparent. So on T2, it's hypointense, with this one right over here. And on T1, it's maybe both. Not sure, maybe this one here. And it looks like there is this. It's hard on T1, I must say. Okay, dot sign. What is the dot sign? Cyst with dot sign. This is a commonly seen MRI feature of the Rathke cleft cyst. This cyst with dot sign. And it's helpful making a diagnosis with sanity on imaging features alone. It should not be confused with the cyst with dot sign of neurocysticercosis. Okay. A cyst with dot sign is observed in 35 to 75% of Rathke cleft cysts. Dot is due to non-enhanced intracystic nodule, which is usually hyperintense on T1 and hypointense on T2 within a fluid intensity cyst. Its visibility may vary depending on the fluid signal, especially making it inconspicuous in one. Cyst with dot sign is said to be pathognomonic for Rathke cleft cyst. The dot is due to a non-enhanced intracystic nodule, maybe this part, which is usually hyperintense on T1 and hypointense on T2. Hyperintense on T1, so maybe this hyperintense on T1. This is hyperintense on T2. Okay, thank you very much. Not sure, so where is exactly the, wait a sec. Yeah, I think this is the cyst, right? This must be the cyst. This must be the cyst, I mean. This must be the cyst. Hyperintense a little bit on T1, so this should be the cyst with dot sign. Thank you very much. If there are mistakes or correction, please tell me. This was about apparently Rathke cleft cyst because of this case. If there are any mistakes or correction, please tell me, and that's it.